Thank you very much. Hi, everybody. I'm John Suffredini. I'm a Baylor interventionalist, but I practice at Bentab Hospital. Tonight I'll be talking about building access, lessons from starting a PFO program in a county facility. And I've been told I have exactly 7 minutes before they turn off the mic, so I'm going to hit the highlights here. Without further ado, I think most people are familiar with Bentab, but it's a large level 1 trauma center here at Texas Medical Center. But most importantly for us in cardiology, it's the only Harris Health system that has a full cardiovascular suite of services, including a cath lab and a CCU, and a very robust financial assistance program for county residents as well. So I think Bentab has always had a very high coronary volume, and the Gold Plus Gold Coronary Care, et cetera, awards. But the last couple years, they've been undergoing significant expansion, building 3 brand new cath labs that just started operation several months ago this year, building new hybrid ORs, starting a TAVR program a few years ago, hiring 2 new interventionalists in the last 2 years, with another job opening open now, and another electrophysiologist, and still continuing to build out a brand new CCU as we speak. As we've expanded, we've looked for ways to continue to grow our program, and Harris County has already had like a pretty extensive stroke program, so moving into the PFO space was an easy transition for us and made a lot of sense. So I think PFO closure doesn't require any introduction for this crowd. I think at this point the evidence base is quite strong for PFO closure for cryptogenic stroke, 4 large randomized controlled trials, and both our SCI guidelines and the neurology guidelines agree on closure for cryptogenic stroke patients. So in 2023, after TAVR was successfully introduced, we looked into moving into the space for both PFO closure and ASD closure. So the first thing that we knew that we had to do is that there was a large volume of patients that had PFO and had cryptogenic stroke, but they were either unfunded within the county and had been receiving medical therapy only, followed only by a neurologist and never seen by a cardiologist, or they were, if they'd had commercial insurance, they were being referred outside of our center and going to other facilities. One of the most important things we did initially was made sure we engaged with our neurology section faculty members to make sure that they were aware that this is now something that was available within our facility. We made sure they had a dedicated point of contact so that when they made a referral, it wasn't like a 14-month wait, but we actually got them in a reasonable time frame. And we made sure our own fellows, too, were aware that this was something that we were offering within the facility. So whenever they saw a patient, either on consults or CCU, et cetera, in the general cardiology clinic, they knew how to get a hold of us and get the patient into our clinic. So one of the most important things we did from the beginning was we already had a fantastic TAVR program coordinator, and he had the bandwidth to become our structural heart program coordinator and take over coordination of care for these patients. Was instrumental for being able to increase our workflow. So just a very brief introduction to our approach. These patients either come from PCP or most often from neurology. Typically they just have a positive bubble study at this stage and then a typical CVA workup. So they reach out, our coordinator handles making sure they get an initial appointment on time. We see them in clinic and assess candidacy, review their prior workup, and if they're going to probably be a candidate, proceed with TEE and event monitor. Once that workup is done and it's tracked by our coordinator, the patient is just very smoothly scheduled for closure without requiring further appointment. So overall, it's a pretty streamlined process. Most of our, just like most centers, we try to be as efficient as possible. We schedule right now 2 to 3 closures back to back in a day, but we're looking to increase that number. We usually run a couple rooms at a time. We either do transesophageal or ICE guidance, depending on the complexity of the case, trying to move more towards ICE guidance because obviously it's more efficient. But we make that decision based on case complexity. Post-op care is pretty standardized. We do a chest x-ray, limited echo. We do 6 months of DAPT at our facility, endocarditis prophylaxis we give to every patient before they discharge. We see them at 2 to 4 weeks afterward. We see them at 6 months afterward, the post-echo, and then we stop DAPT and stop our dental prophylaxis at that stage, and then we return them to their primary cardiologist or whoever had referred them to us at that stage. So Luckily, over the last few years, since we started the program formally in 2023, we've had continued growth in our volume every year, and we're looking to continue that. This year, we're looking at probably 35, 36 closures, up from, I think in 2022, we did a single closure. So we're certainly moving in this direction. And if you happen to have a patient that needs ASD or PFO closure that resides in Harris County, we're very happy to take your referral. So just reach out. I do have to say thanks to everybody who's made this program possible, including Dr. Parekh, who's been an incredible mentor, Dr. Kiani and Gia, who are my partners, our non-invasive colleagues, for all the time they've donated doing our TEEs for us, and Jerry Gonzalez, our incredible coordinator. Thank you, guys.